Hello, everybody. Welcome back to the Club Nurse Podcast. My name is Colton Lord, your host. Thank you so much for being here. I have so much gratitude. I'm so grateful that you take the time out of your day to come listen to this podcast and gain whatever kind of knowledge or just entertainment that you're looking for. If you are watching this on video, yes, I really am just sitting in my bed in my scrubs. I am in the process of moving. So the little makeshift studio that I had kind of put together, it really was not a studio, but it did have some lighting and my club nurse sign and everything is really boxed up, being moved. So I'm in my bed right now. The lighting I'm using is just the natural light from outside. So if the sun starts beating on my face, I'm sorry. It's a pretty cloudy day, so we'll see. But I thought we would talk today about triaging. This idea came to me because I was thinking about a lot of the questions that I get is around remote work and how do you find jobs from home and things like that. And I was thinking about it and I was like, learning how to triage or knowing how to triage is actually a really specific and useful skill in a lot of different specialties. And even if you're not working in the emergency department, you are triaging. I mean, think about this. If you're working in the ICU and you have two patients, the prioritization of the patients that you're seeing and the things that you need to be getting done, if you're working on the med-surg floor and you have 5 or 6, and I hope not any more than that, patients, you're in your head, you are really going through a triaging process of who do I need to see first? And we learn that in nursing school. Like you need to prioritize your tasks, get what you can get done first of, what's the most severe, what is the most potentially life-threatening, or what medication needs to be given in a very timely manner. These are skills and things that we learn from the very beginning of our careers. But specifically working in the emergency department, you learn how to triage patients who are coming into the ER and assigning them a number. So I thought, this would be really helpful and beneficial. And maybe even if first of all, if you're an ER nurse and you have not been trained on triage yet, I feel like this is something that's beneficial, kind of gives you a introduction into what you might expect in the future. If you work in other spots at the hospital, other departments, I think this is also helpful to get an idea of how the ER nurses are triaging these patients. And I'm sure you already have a pretty good idea. But say you get a patient to the ICU, to the med-surg floor, to your step-down unit, and they have a little number next to them, and you're kind of like, I wonder how the ER nurses are assigning them these numbers. Like what exactly is being done when the patient hits the ER that's giving them this specific number. So let's go through it. And then also, if anybody out there is listening and you're not in healthcare or you're not a nurse, or if you are a nurse or in healthcare and you have family members who maybe have to go to the hospital a lot, or you just want to educate them, this is a great episode to send to somebody just to enlighten them on why when you go to the ER and you've been sitting there for an hour, 2 hours, and somebody walks through the door and they immediately get to go back and you're frustrated, maybe just knowing this information will help to alleviate some of that annoyance or that stress or whatever you're feeling at that time. Because I understand when you've been sitting out there, it's a super busy night, and you've been sitting there for 3 hours waiting to get back into the ER and you don't feel well, or you have a family member who doesn't feel well, that has to be so frustrating, but it's for a good reason and there's really no way around it. And so I thought, why not just talk about it? So let's kind of go through it. I did take some notes. So if you see me grab my phone, that is why. So when somebody comes to the ER and you are the triage nurse, and I've worked at a few different ERs, and it's obviously it's the same system as far as assigning them numbers, but every hospital I've worked at does have a little bit of a different, process based on how the ER is set up, or what kind of staffing they have, how the flow is kind of ran. But what the basic system is, there are 5 numbers that we choose from as a triage nurse. So there are numbers 1, 2, 3, 4, and 5. 1 being the most severe, 5 being the least severe or the least urgent person to be seen. And so what we call this system, I knew it was called ESI, like what ESI are we assigning them, but I actually didn't know what it stood for. I'm sure that I've heard this before, but if you were to have asked me, what does ESI stand for? I would have been like, I actually don't know. But it stands for Emergency Severity Index is what ESI stands for. So I looked this up just to kind of give you like the textbook definition of what each of these numbers are. And then I'm going to go through each scenario, each number, and give you an example of somebody who would come into the ER and what number they would give, just to give you more of an idea on this. So let's kind of just start from 5 and go down to 1. So level 5 is a minor complaint. So basically, and these are also based on like resources, like how much resources is this patient going to need to be seen and either go home or be admitted to the hospital. So a 5 is somebody who is stable and requires no resources. And so these are very rare. You don't see these very often. These are typically some people who come in who just need like a medication refill, and that's all that they need. Like no imaging, nothing. They just ran out of their insulin, so they came to the ER. They ran out of their antihypertensive medication for their blood pressure, so they came in to be seen, and that's all that they're there for. No other complaints. And you know what's funny? They're given a 5, which is the least severe, but they are typically in and out the quickest, because usually there's some kind of fast track system in the ER that gets them in and out. Like, okay, just come back. You'll go to our fast track area. The provider will see you, do a little assessment, prescribe you whatever meds you need, and then they leave. All right, so then the next one, level 4, these are called non-urgent. So these patients require only one resource for their care and have a stable condition. So examples of this, one resource will just be an x-ray. Like they need an x-ray, they came in there, they hurt themselves, they shouldn't need anything else, and then that's it. So 4s and 5s, again, they typically get seen a little bit quicker, only because there's usually a fast track area. A level 3 are urgent patients. So the definition of this is patients with a stable condition who require multiple resources, such as lab tests, imaging, or IV fluids. They may have to wait to be seen after level 1 and 2 patients. Again, sometimes though, depending on the facility, these level 3 patients sometimes too can get away in these fast track areas. Again, I'll go through some examples so that you kind of understand better how the flow and the function of the emergency department is working. All right, so that when we get to levels 2 and 1, these are when things become more serious. So a level 2, by definition, are an emergency level patient, high-risk patients whose condition could become life-threatening. This includes those with a threat to life, limb, or organ, severe pain, or a significantly altered mental status. They must be seen quickly, though not necessarily instantly. Yeah, so 2 is a big deal, but they're not always going back immediately. So easy. It's so weird. Like, hello, I can go run 6 miles, but I can't sit here and have a conversation on a microphone. So a level 1 is an immediate patient, the most critical patients who are unstable and require immediate life-saving intervention. They are seen immediately and often involve conditions like cardiac arrest, severe respiratory distress, or unresponsiveness. So that's kind of your levels of 1 through 5 of the ESI. So kind of how this works. Somebody walks into the emergency room and they sit in your triage booth, or whatever it is, your triage counter. They're giving you their spiel, what's going on. You're triaging them. You're typing out your note. And once you type out that note, then you get through everything. You take their vital signs. And based on that, the nurse is responsible for assigning them a number. So when you work in an ER, typically you're given some kind of module, some kind of health stream, whatever your facility uses. It walks you through, like, you are tested on how to assign people numbers. And there is a system to it, but these things are objective. And, there are some very black and white, cut, clear, you're going to get a 1, you're going to get a 5. Like, these are very obvious ones. But there, as in health, in everything in healthcare, there's a lot of gray. There's a lot of things that you just have to use your clinical judgment. And, one person may give somebody a 3, the next may give them a 2. That's kind of where it gets gray, is like 2 versus 3. In my experience, if I'm ever kind of on that fence, I would rather just give them the 2 and just be safe than like give them a 3. And then they wait longer and I missed something. I would rather just have that peace of mind. I triaged them up a little bit, no harm, no foul. Like, they got back, they got seen quicker, nothing was wrong. The provider might be like, why did the triage nurse give them a 2? And that's okay. I would rather that, and I would rather have that conversation, a little bit of education, understand a little bit better, move on. But, that goes back to like nursing intuition. Shout out to our girl, Nurse Jen. We had her on the podcast. I highly recommend you listen to her episode with us. It's just that gut feeling that when sometimes you just have that weird feeling, like everything looks okay, but you're like, no, something's wrong. I'm going to up-triage them to a 2. I'm going to let the charge nurse know. I'm going to let flow know, whoever's running the flow of the ER know that this patient, I think, needs to be seen, or, a doctor needs to lay some eyes on them. And that's okay. That's part of it. That's where we learn. And sometimes you'll have those little hunches and you will be surprised at how right you usually are. I actually have a great example for this. I was working at my job. As most of you know, if you've been listening to this, I work for a job right now where I work from home. I do a transfer center. Basically, my job is mostly triage. I'm not actually assigning them numbers in this job that I have where I'm transferring them. But my job is triage. I have to triage them and get them to the appropriate service. I had a call yesterday and it was for a cardiology patient. With our process, if it's a cardiology patient and they're okay to go to the floor, we just kind of auto accept them. We don't have to necessarily talk to a doctor. And I just had a hunch. I had a weird feeling. Nothing screamed ICU in the case. I had already accepted the patient, but something in me just was like, no, just pause for a second. Let's think about this. I was worried about the blood pressure. It was a little bit borderline low. They weren't on any kind of pressors or anything, but I just had this feeling. I had a weird feeling. I'm like, I'm just going to run this by the ICU, the cardiac ICU attending, just so they can tell me whether or not they should come to the ICU. I ran it by him. Lo and behold, he was like, you know what? They probably could go to the floor. We don't have any beds. Let's just get them over to the ICU just to be safe. And literally ended that call. 5 minutes later, a outside facility, the nurse at the other hospital who was transferring us the patient called and said, hey, this patient's blood pressure is tanking. I think they need to go to the ICU. And it was like, oh, no worries. We already did that. Already had that hunch. Already spoke to the ICU attending. We'll get them a bed. And so, yeah, it's just those feelings. Again, there was nothing about it that was like screaming at me, ICU. They technically, per my standards, whatever, could have gone to the floor. I just had this weird hunch, this weird feeling based on their history and the clinical picture. So I called the cardiac ICU attending. We accepted them, and then they ended up needing the ICU anyway. So just trust that. And I'm not saying that happens every time. There's some times where you do things and the patient's fine. The gut reaction maybe wasn't correct. But in those situations, you just listen to yourself because you just never know. So always err on the side of caution. And that's what I'm saying about like up triaging. If you're questioning 2 versus 3, it's kind of gray. Just go with the 2. Like you're never going to be wrong in that situation is what I'm trying to say. Okay, so let's run through what these patients walking into the ER and how we assign them the numbers. Okay, again, so we'll start with 5 and go up to 1 again. The 5 and 4 is very, very quick and easy. 5, somebody comes in. I already really said this. They come in, they're diabetic. They ran out of their insulin. They can't get to their PCP. They just need a refill. Somebody's on vacation. They forgot their blood pressure pills at home. That's all they need. So they come in, refill, they're out the door. Again, these usually in an ER, there's usually a place called fast track, which functions really like urgent care on steroids. So typically in these fast track areas, from my experience of multiple ERs that I have worked in, there's usually, depending on the size of the ER, anywhere from 2, really sometimes there's only 1, but usually like 1 to like 4 nurses who are kind of navigating, getting these patients in and out quick. And this includes sometimes just putting IVs in patients, sending off their blood work. And this even is for like patients who are ESI 2. They just let's just get their blood work going while we wait for a bed. That way, by the time they get to the bed, hopefully the idea is that the blood work's already back. Maybe they've already had an x-ray or a CAT scan, and it just expedites the care. It's that way they're not like waiting, sitting in the lobby. And it's great because if we send off their blood work and they're sitting out there and a lab comes back critical, it's like, oh shoot, like we need to get them back quicker. And now we already have the evidence and we know that. And that's why we do things like that. So anyways, this fast track area, this urgent care style of nursing within the ER, that's where that 5 will go. I need the med refill. Okay, get you back. Doctor sees you, fills the prescription, writes their note. We discharge them. It's quick. That's the idea, given nothing else comes up. All right, so let's go to a 4. Person comes in. They were playing basketball, twisted their ankle. They probably just need an x-ray, maybe some Tylenol, ibuprofen. And this gets again, murky. It's like, okay, well, is that considered 2 resources? I think you would have to look into the exact guidelines of where you work or whatever. That would be a 4 to me if somebody came in, and even if we gave them Tylenol and an x-ray and you consider that 2 resources, whatever. It's a 4. We get them back. We get the x-ray of their ankle. Maybe they need a little bit of a brace. Doctor discharge or PA or nurse practitioner, whoever discharges them, they're on their way. Easy breezy, hopefully, anyway. Oh, and this is also a very important point to make too. If you ever assign a patient a number, you never, ever, ever change that priority down. So say somebody came in and you initially had triaged them a 3, and then for whatever reason, this should never happen. You change your mind and then you switch it to a 4. Never do that. If you already made them a 3, you just leave it. If anything, you up-triage them. So say you have a 3 sitting out there and things are looking like not good, you could always change it to a 2. Up-triage them. Get them in quicker, but never change that from like a 3 to a 4 or a 2 to a 3. You always want to keep it either at that number or up-triage them. Does that make sense? I hope that makes sense. Okay, so we explained the 5s and the 4s. Typically, those will go to fast track. The idea, get them in, get them out. They shouldn't be there for too long. And that's the idea. It doesn't always work out perfectly depending on what's happening. The ER is a crazy place. You never know what's going to happen. Okay, so an ESI 3, this is where it gets a little bit more interesting. And again, a little bit more gray. So say your patient comes in and they have abdominal pain. A lot of abdominal pain patients are an ESI 3, but sometimes they're 2. If this person comes in and they're like, oh, like my stomach hurts, and they're like 25, my stomach hurts, like it's been hurting for since yesterday after I ate this food, I've been throwing up, I can't keep anything down, I feel so dehydrated, like that's a 3. They're gonna need an IV. They're gonna probably need some IV fluids. We're gonna send some labs off, and maybe they're gonna need like a CAT scan or an ultrasound to check out what's going on inside there. That's a typical like cookie cutter 3, ESI 3 of a patient. I'm trying to think of another example for a 3. Another one that might be a 3, somebody who comes in with just like a really bad headache. Maybe it's like a 40-year-old. They're like, oh, my head hurts so bad. I don't usually get headaches, but they're not confused. Neurologically, they are intact. You're not worried about like a stroke. They're going to be an ESI 3 because again, they're probably going to need an IV. They're probably going to need some labs. You're going to likely give them some pain medication or something for that headache. And then depending on what's going on, they may end up needing to get a CAT scan of their head, make sure there's no like brain tumor or something going on intracranially. Is that a word? Intracranially. So those are your 3s. I hope that makes sense. So when we get to level 2, ESI 2, these are like why I feel like nurses become ER nurses. Like this is, I hesitate to even use the word fun, but this is where the fun comes in. And it is, I mean, these are people's lives and like it's not fun for them, but like there is a level of excitement and adrenaline in being an ER nurse in these settings. Not saying that like we want these things to happen, but like that's why we're there. We want the experience. We want to be the people helping. It's intriguing. It's interesting. We like the interventions. Like whatever it is, it's okay that it's a little bit fun. Again, you can say that with like compassion for the people that are going through that because it's obviously not fun for them. But if somebody didn't find the job fun, then people would be in trouble because there would not be any ER nurses out there doing the job. Okay, so a level 2 patient. Somebody comes in to the emergency room. You're in your triage booth, and this guy comes up. He is 48 years old. He's like, oh my gosh, like my chest hurts so bad. I was mowing my lawn and like all of a sudden I just got this really, really bad chest pain. When I sit down, like it feels a little bit better, but it really hurts. That's an ESI 2 all day long. Like chest pains typically ESI 2. And what we would do in that instance is, okay, you get your little story down and you would immediately get vital signs and grab an EKG. That EKG is vital. A lot of patients who come through triage get an EKG just to rule out anything immediately life-threatening on the EKG. But the chest pain, obviously very important. You get that EKG and you hand it to the attending provider. The attending provider makes the decision, okay, this is not a STEMI. They don't need like an immediate cardiac catheterization. So that's great. But you give them a 2 because you're concerned. They probably are having some kind of cardiac event, but it's not immediately life-threatening is basically the point that you're kind of making there. I really got to figure out this breathing thing. It's like I want to lay down. This is normal with podcasters or people who talk. Like you run out of breath. I need to learn how to breathe. And I lost my train of thought. That's what I'm saying. Okay, so with that chest pain patient, say that the ER is full, there's no beds for them to immediately go through. Depending on where you work, okay, I'm going to notify the charge nurse, hey, I'm really worried about this patient. He's okay right now. His vital signs are like okay, but he's really got a lot of chest pain. I'm really worried about him. Okay, we'll keep him on our radar. We'll get him back as soon as we can. That's the idea. So this patient may have to go sit back in the lobby, but you're going to keep an eye on them. Depending on where you work, you don't always see these people. Like I've worked places where your triage booth, you can see the entire waiting room, which is a good thing because that way you can like see what's happening. But sometimes you're like locked in like a booth, like where there's like a door and you can't see through it. Like you can't see what's going on out there. And that's great for like patient privacy, but like you can't see what's happening out in the lobby, which can be kind of concerning. But in places like that, there's usually like a front desk person or security that's out there that can see the lobby. But it's like, well, who's liable for these people? Anyways, that's neither here nor there. Huge, there's always concerns in any department you work in. But the idea is like the triage nurse is kind of responsible for these people that they're assigning a number to. So that chest pain person who's not having a STEMI may have to sit in the lobby for just a little bit until they can get a room back in the ER. But they're high priority, like they're on the list to get them back quickly. Another ESI 2, this could be an abdominal pain who's like really in like severe pain, like you like barely like drag over their stomach or their abdomen and they're wincing in pain. Like that's probably a 2. you're concerned for, a ruptured appendix or something like that. There's so many things that can be going on with abdominal pain. And if they're in that severe of pain, or depending on their history, those ones can get a 2 as well. Anything like somebody comes in with like stroke-like symptoms, like that's a 2. And those usually those go back immediately. Like if you're concerned for a stroke, those ones get back. They need to get into the scanner. You need to be able to see what's going on in their head and give them those stroke medications like TNK or TPA, depending on what's going on, because as we learn, time is tissue. With strokes specifically, there are very specific time windows on when you can do interventions, and it's very, 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 very important. So those ones are like, again, it might depend on where you work. Like some may assign those a 1, but in my experience, it's like slap a 2 on them. They're coming back anyways. Sorry. I don't think anyways is the proper way to use that term. Anyway, they are being brought back. You're never going to send a question of a stroke back to the lobby. I've worked somewhere where if you were kind of like gray on like stroke-like symptoms, you would have, you'd kind of call the attending provider. We used Vocera. You would call the attending provider up. They would come do like a stroke assessment. And if they were concerned, we'd send back to the scanner, from the scanner to a room. If they're like, no, they're good, send them to the lobby. Then, well, you can document provider saw patient or provider did neuro assessment. Okay to wait for a room. But usually if it's neuro symptoms or stroke-like symptoms, they're going to like just get them to the scanner, because it's kind of hard to tell. And sometimes those stroke evaluations can be, again, very murky, very gray. It's very objective, and you don't want to risk anybody's life or brain because you're not quite sure. But yeah, another one I wanted to touch on with ESI2 really quickly. Anybody that comes in with suicidal ideations, immediately a 2. Like that is immediately a 2. They're immediately a high-risk patient. They're going to need somebody with eyes on them at all times. It's no question. They're ESI2. They need to come back until, again, so they can get an observer. The ER provider can see them, and the site can also come see them. It's a big deal. You want to get them back quickly. It's something that we take very seriously in the ER when you come in with any kind of suicidal ideation. Okay. And then we get to the level 1s. These ones are also usually pretty easy to assign numbers to. So if EMS is coming in with a patient in cardiac arrest, hello, it's a 1. Like they're already getting their life-saving intervention. You slap a 1 on that baby, and then you move on with your day. Also, in my experience, I've had patients who I've been sitting at the triage booth. Somebody comes in with their boyfriend. The patient is the boyfriend, and he had a procedure that day, having a really hard time breathing. He's just like really, really working, and you're already concerned looking at them, but you slap the pulse ox on them, and they're like high 70s, low 80s, and their oxygen levels. No, like you're coming back. Like there's no way you can go sit in the lobby with that looking the way that you do. Like that's a 1. That's immediate. Like get back. You probably need some life-saving intervention. In that case specifically, he had some kind of procedure that day, and if I'm not mistaken, from whatever they had given him, I don't remember if it was propofol for sedation. I may be wrong on this, so don't quote me, or I don't remember if this was a side effect, but he had flash pulmonary edema. And so that was immediate. He needed to come back. Like he needed care like right then and there. I've had patients where, like if there's like a gunshot wound, and sometimes if it's like gang related or something, like sometimes they'll just drive by and dump the person out and keep going. Like that's a 1. Like they need to come back now. If you got shot, you need to come back now. So anything like that is a 1. Yeah, so life threatening. You need immediate life-saving intervention. It's really the 2s and the 3s where it's like a conversation on like, where are we going to go with this? And like I said, if you're ever on that fence, just give them a 2. Just give them a 2. If you're new to triage, you can also kind of just ask somebody, like phone a friend, like, what do you think? But again, I just always err on the side of caution, because why not? I'd rather give them a 2. I'd rather get them back. And if it's nothing, and if it's happening continuously or over the kind of the same thing, then it's just an education thing. And you, through experience and triaging people more, you'll become more accustomed to like, okay, I am comfortable giving them a 3 now based on what I'm seeing. And you can always up triage. If you give them a 3 and then you change your mind 10 minutes later because you check their vital signs again, it's fine. Change the triage. All right. So that's how you triage. That's how it works in the ER. I hope that helped anybody out there. I've worked in different ERs. Like I said, it really functions differently everywhere you go. Something that's pretty straightforward across the board is when you walk into an ER, there are 1 or 2 nurses typically that are going to triage the patients. The setup's obviously going to be very different depending on where you work, but it's pretty similar. They walk up, they get registered or whatever, and then you triage them, and then they wait in the lobby or they come back. Like that's the process. Where it's really different is I've worked in places where there is somebody who is assigned to ambulance triage. And I've worked at multiple hospitals where there is a specific nurse who triages all the ambulance patients. And then I've worked where I started, the first ER I worked in, you triage your own patients. So if a patient came in via EMS on an ambulance, the charge nurse may screen them to make sure like they obviously it's not like a trauma or that they need to, go straight to like a scanner or something. But the primary nurse is triaging those patients. So say you have your 4 assigned rooms and you have an ambulance coming and they get slotted to your room, you triage them. So I liked that because from the get-go, you are learning how to triage, but you're not getting it to the same volume as triaging the lobby. And since they're already in a room, like you're not going to really get dinged if you triage them the wrong number and they're waiting in the lobby because they're already in a room. Do you see what I'm saying? I know it might sound kind of weird or hard to understand, but if there's not an ambulance triage nurse, those ambulances just land in the room and the primary nurse taking the patient will triage them. And that's how, it was where I started. And then once you kind of get some experience, then you can move to the front where you're like the main triage nurse. I did one shift where I was the triage nurse for 16 hours because I was there all day for 12. They needed some help and I stayed for 16. And I still remember that day because it was so long and that's a long time to be sitting up there. And I'm pretty sure that there's research on how that's not great because the longer that you're up there and the more that you're seeing, the more likely you are to kind of miss things. Not just because you've just been listening to people all day tell you their problems or what's going on with them. And so you're more likely to kind of like miss something if you're up there for that long. So I don't recommend 16 hours in the triage booth, but it does happen sometimes. And you just got to kind of roll with it. So yeah, that's my triage life. That's my triage knowledge. And I hope that helped. Again, they are based on an ESI, Emergency Severity Index, 1 through 5. 1 is life-saving. You need immediate care. 5 is not urgent. You just need a medication refill. So yeah, I hope that helps. It's coming from an ER nurse. I have worked in the ER for 5+ years-ish in multiple different ERs. So I do have some experience. I'm not the most experienced person, but I do understand the triage process. I have also, again, my job that I do now where I work from home and also in the office, my hybrid role is really triaging all day long. I'm not assigning numbers to people in my current job, but it's still triaging. So yeah, I hope that helped. And always, 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 always follow your company's policies. Again, when you're going through your training, there's likely a health stream or some kind of module that you have to complete. So always follow what they say. This is just a basic standardized ESI 1 through 5 that I have been trained and know how to use. So again, always listen to your company and their policy. That's a wrap on this week's episode of Club Nurse. Thank you so much for coming by, for listening. I appreciate you always. My name is Colton Lord, the host of this podcast, Club Nurse. You can find me on Instagram at Colton Allen Lord or at Nurse Colton. The podcast is at club.nurse. That's where we post all the podcast things. You can listen on Spotify, Apple, Nurse.org/Club Nurse, or on YouTube. We are starting to post some of the video segments, which is super cool, super fun. And if you want any up-to-date news articles or you want to know what's happening in the world of healthcare and nursing news, be sure to check out Nurse.org/news. All right, we'll catch you guys next time. Bye.